This morning we have the pleasure again of having him speak to us about pediatric pneumonias. Just to tell you a little bit about Dr. Fisher, he initially commenced his medical training at the medical school of the University of California at Irvine, and subsequently he did his pediatric residency at the University of Utah, and thereafter he completed his training at the Tropical School of Medicine in Liverpool, England. And he has, not only does he have an outstanding academic education, but he also has much field experience. In fact, he practiced, researched, and taught pediatrics in Zaire, now known as the DRC, Democratic Republic of Congo, for 6 years. And he currently is the professor of pediatrics, and he is the chair for global child health at Mayo Clinic in Rochester, Minnesota. He's also married to his wife, Julie, and they have a large family of 5 children. And Dr. Fisher, with that, I'm going to turn it over to you. Again, thank you so much.
Good morning, everybody. We're going to be talking about doing low-resource things, but you're stressing me to high-resource. I have never used an emoticon before this morning, so thanks for taking me on to higher levels. But could I know who we are here? I see names on the list here, and I heard voices and saw the imaginary smiles of others of the CHP people. Anne, who are you? Is there an Anne?
Yes, hi. My name is Ann Yakey. I'm a pediatric intensivist by training. I'm currently working at GlaxoSmithKline in their R&D division, and I've done some projects with Samaritans first, so really grateful for you taking the time.
Fantastic. Nice to meet you. And Chad, where are you and what are you doing?
Hey, Dr. Fisher. This is Chad Cole. I work with Royal Medical Mission as a logistics coordinator. I'm an EMT in North Carolina as well.
Fantastic. Greg? I'm not hearing a Greg answer. We heard from Kelly. Laura, are you with us?
Laura had to speak.
Or Mary Lou or Pam, are you there?
Here, I'm Mary Lou Fisher. I'm the National Health Advisor for Samaritans First and have been around the organization for quite a few years. Thank you very much, Dr. Fisher, for speaking with us.
Well, thanks to you all for being here this morning. I'm looking forward to a good time. I think the plan is that we're going to talk about pneumonia. And I'm hearing my voice echoing back through the phone. Is everybody else hearing an echo too?
We did just briefly, but I took care of that. We had a microphone that was still on, so that should be alleviated.
All this technology gets me so excited I'm breathing fast, but that's what we're talking about. We're going to talk about hot stuff and breathing fast, how to take care of kids with fever and respiratory distress in developing countries. We'll cover some standard things, and hopefully this will be useful to people that are taking care of kids in resource-limited areas to help us be able to take better care of these kids to bring them through their illnesses. Most of us have had opportunities to be working with kids with respiratory distress, whether it's from the heart disease or something else. So we can frame our thoughts, I think, by considering a child. If you can see the screen, the first child we'll consider is a 10-month-old presenting with 2 days of fever and cough. What we want to know is what we need to do to make the appropriate diagnosis, and the diagnosis is useful because it can help us know what kind of treatment is most likely to help this child. It should be a fairly straightforward plan or opportunity to make a diagnosis and get treatment, and we'll see how straightforward it can be. Certainly pneumonia is a major concern, and decades ago in England they were concerned, so they put up posters around the town of Hempstead saying pneumonia strikes like a man-eating shark. Those that have been gripped by pneumonia realize it can be serious, and it's a big deal around the world. Each fall now the world commemorates, not celebrates, but commemorates World Pneumonia Day, where people can get together to hopefully fight pneumonia and save a child. If the half dozen of us together on the phone this morning, or probably a dozen of us even, if we could each be involved in a child's life in this next year, in fact, we can save scores of children through all the people we influence because pneumonia is such a common problem. And in fact, there are over 1 million kids dying every year because of pneumonia. It's estimated that 1.2 million preschool children die because of pneumonia and never even reach the opportunity to be old enough to consider going to school. Sadly, many of these cases of pneumonia are vaccine preventable, and perhaps more sadly to those of us involved in clinical care, only about a third of the children with pneumonia are provided antibiotics that could be useful in facilitating their recovery. So there are problems because of pneumonia, and we want to do something about that. So we'll be talking today about what kind of action we can take to prevent some of those deaths. We'll be thinking a bit about vaccines and reminding ourselves that preventive care is as important as the treatment. But in fact, we'll focus most of our thoughts on dealing with that inadequate care problem of how we can best diagnose and treat pneumonia. If we pause for just a second, is the technology working? Can people hear my voice okay?
Yeah. Yes, sir.
Everybody's okay, and slides are working for people? Okay. So pneumonia is a common problem. I've seen a bed in a developing country where there were 3 young children, all with fever and respiratory distress with tachypnea, sharing the same bed, sharing the same oxygen concentrator. Many of us have worked in similar sorts of places, and some of you have probably even seen this bed. This bed was actually in Mongolia, where some of you CHP folks have been hanging around with sick kids in their ICU. So we'll ask the question, and we'll see how technology works for people to out loud give your answer after I read through these. But let's imagine that a 2-year-old is febrile and coughing. What equipment is most useful in establishing a diagnosis? We want to know, is this pneumonia or not? What piece of equipment would be most useful in helping us establish a diagnosis? You can say A if you think it's a blood count machine, B if you think you need an x-ray machine, C if you need a stethoscope, or D if the best equipment would be something else. What are your thoughts?
Stethoscope.
One person wants a stethoscope, and the rest of those Beth-type CHP people that are remaining quiet in the background, I guess. All right, I see a bunch of C's. I see a bunch of votes coming in there, people voting for stethoscope. I will actually suggest to you that D is the correct answer, that none of the above. So if this is a democracy with majority, stethoscope wins. But I will suggest to you that it's the wristwatch that's the most important. As demonstrated in this old slide, somebody can look at the watch, watch the child breathe, and count the respiratory rate. It's been said and taught by World Health Organization and others, and it bears out in clinical practice, that measuring the respiratory rate is the best way to decide if a child has bacterial pneumonia. If we count the respiratory rate in a child between 2 and 12 months of age, and it's more than 50 breaths per minute, that would count as tachypnea. So in a febrile, coughing child, if there is tachypnea, we would consider the diagnosis to be bacterial pneumonia. If the child's 1 year to 5 years of age, we would use 40 as our cutoff to make the diagnosis. And if there is tachypnea, then we would consider that bacterial etiologies are most likely, and we would give an antibiotic, either amoxicillin or cotrimoxazole if the child's not too sick, and parenteral treatment with ceftriaxone or penicillin if the child is sicker and retracting. This slide that you're looking at right there can be considered to be the mainstay of what we really need to know to take care of pneumonia in developing countries. Look for tachypnea, and if there is tachypnea, give an antibiotic. And I wish we were done and life was that simple, but I remember back a few years ago when some of us are old enough to remember, there was a guy named Bob Dylan who said and sang, "The times they are a-changing." And in fact, this idea that we were just looking at, that all we need to do is count the respiratory rate and then give an antibiotic, times are changing, and it's not clear that that's the real answer and that that's all that true anymore. Life is a lot more complicated than just counting a respiratory rate, and that gives us some things to talk about. Even Bob Dylan has grown a little older. I don't know why he was wearing sunglasses inside when he met with Barack to get the Medal of Freedom a few months ago. But times, they are a-changing, and things are different. So we'll talk a bit about the diagnosis and treatment of pneumonia, realizing things are changing and getting more complicated. So, what causes fever and pneumonia? Or sorry, what causes fever and tachypnea? There are lots of causes possible. Bacterial pneumonia is certainly our major concern. For those of us that work in parts of the world where there's malaria, malaria by itself with no specific lung disease is associated with fever and in sicker kids tachypnea. Viral respiratory infections cause fever and tachypnea. And then lots of kids have multiple problems where it's fever plus something else. The something else could be metabolic acidosis from diabetes or dehydration, or they could just have a fever and be anxious and be tachypnic because of that. I'm probably got the anxiety of tachypnea today using all this great technology and getting to talk to you all, but I don't know that I'm febrile. So anyway, there are lots of causes of fever and tachypnea, and we have to consider all of this when seeing a child. The child does not come in with their diagnosis etched on their forehead, so we need to consider all the diagnostic possibilities. So our goal is to decide initially, is it pneumonia, so we know whether or not we need to give antibiotics. The old way, which is still somewhat useful, is just to count the respiratory rate to decide. But how effective is that? There was a study a couple of years ago in the Pediatric Infectious Disease Journal that pointed out that tachypnea by itself was not very predictive in diagnosing pneumonia. They looked at 1,600 kids in an emergency department in Boston. These were preschoolers that clinically were thought to perhaps have pneumonia. 20% of the tachypnic kids had X-ray evidence of pneumonia, meaning 80% of them didn't. And 12% of the kids who were not breathing fast also had evidence of radiographic pneumonia. So if we believe that the X-ray is the ultimate answer about pneumonia, that would tell us that the respiratory rate is not very discriminating, but it was a little bit predictive, but just not very exact. So our idea of just count the respiratory rate to make a decision was questioned here, and it didn't hold up very well, using X-rays as the definitive answer. The same group in Boston looked at all kids up to age 20 and compared what was going on with them, and they found out that if they were hypoxic and not wheezing, then they had a fair chance of having pneumonia. If on the stethoscope exam, for all of you that said C, stethoscope is your right answer, if there were focal or localized rales, crackles, then there 2/3 of those kids had pneumonia. And in that study, tachypnea and retractions were not necessarily linked directly to the diagnosis. So the setting here is a Boston emergency room. That's a little different than the settings that we might be talking about in resource-limited countries. And this is using X-ray as the ultimate answer. So all of you that said C when we were answering that, you can feel validated that you might be right and I might be wrong. If we look at the WHO criteria, that tachypnea with the 40 and 50 numbers that we talked about, the same group in Boston did a different study in the emergency department, and they categorized by age, using for preschoolers the 50 breaths per minute or 40 breaths per minute at those two ages. They found the sensitivity and specificity of using tachypnea was pretty lacking. It was somewhat valuable, but not very valuable at all. So how do we interpret this? Do we say that I and the WHO are wrong and you all are right? Well, maybe that is the right way to interpret this, that we should think more about the stethoscope, or that we should get X-rays everywhere. Or is there something else going on? It could be that maybe the X-ray is not the right answer. A few decades ago, there was a study done in Toronto where they gave pediatric radiologists X-rays of children with possible pneumonia. And those pediatric radiologists reviewed a whole bunch of X-rays. Some of them they reviewed twice without knowing they were seeing the same X-rays twice. And it was fairly clearly shown that pediatric radiologists don't agree with each other or with themselves and are not very consistent about what they call a bacterial pneumonia versus something else. So maybe the X-ray is not definitive, which prompted one review a couple of years ago to have this title, suggesting that maybe X-ray was not the gold standard, but just a bronze standard. So maybe the problem is that tachypnea means something, but X-ray is not the perfect comparison to know what it really is. So then the question might come up, well, what else could we do? And this is where things start getting a little exciting in recent years. some of us would look at this, and if we didn't have the labels, we would think it was about to snow again in Minnesota. Others would say it's always about to snow again in Minnesota. But one way or the other, this is an ultrasound view of a child that had fever and tachypnea, and the labels make it look like there's a consolidated area in the chest. It's possible to teach ultrasound use to people at point of care in an emergency room or a clinic setting where kids are coming in. And perhaps ultrasound would be cheaper, more readily available, and maybe even more accurate than an X-ray for diagnosing pneumonia. So a couple studies have been done. 4 years ago in New York during the influenza H1N1 epidemic, people looked to see if ultrasound might be useful to diagnose pneumonia. And the key finding of this study, done a few years ago, just reported last year, was that there was reliability between people. So people could reliably decide if they thought it was pneumonia by characterizing the the ultrasound as showing either bacterial infection or viral or both or neither. And that K-kappa score shows that there was fairly good reproducibility as people did the ultrasounds. So this would say that ultrasound might be reliable between observers as they look to see about pneumonia. Another study was done in New York looking at 200 kids, 1 to 8 years of age, so preschool and early school years. And again, this study compared using X-ray as the gold standard or the final line. And out of the 200 kids, about 36 of them actually had pneumonia. And this showed that the ultrasound was fairly sensitive and specific to match up with the X-rays and what the X-rays show. I have never used an ultrasound to diagnose pneumonia, but maybe that's the coming thing. Last year there was a study, opinion in Acta Pediatrica that you can see a little bit blurry there. Kelly, welcome to joining us. You can see the Acta Pediatrica title that was under the column A Different View, suggesting that lung ultrasound for pediatric pneumonia diagnosis might be internationally accepted in the near future. Within a few months, an American journal came out with this, and they actually suggested that ultrasound for diagnosis of pneumonia was ready for prime time for routine use. So maybe the days are coming where instead of just thinking about tachypnea and instead of using X-rays as a gold standard, maybe we're getting close to the time where we might use ultrasound. Those of us that work in or visit other countries around the world would be pretty thrilled, I think, if this was going to work, because ultrasound is readily available, fairly quick, and inexpensive once the machine is available there. So that might be something coming for the future. So what are we going to do to diagnose pneumonia? I'm still old-fashioned, and I'll still count respiratory rate. The stethoscope can be useful, but especially in young children, it sometimes can be misleading. But part of the trouble is that we don't have a real gold standard. Maybe ultrasound will prove to be useful. So one way or the other, with some combination of our clinical interpretation of respiratory rate, ultrasound, X-ray, clinical exam, we will come up with a diagnosis. If we're going to treat the child, we'll have to be thinking about what the bacterial causes of pneumonia are. The fine print on the table that you should be seeing now suggests to us that there are a lot of bacteria that cause pneumonia, but that the most likely ones vary with age. So in newborns, in the first month or so of life, it's group B strep and E. coli that are the most likely causes, or if the child has had some sort of a procedure or some medical intervention, then Staph aureus becomes more common. So the newborns have different germs than the rest. After a couple months of age, pneumococcus becomes the most common cause. And if there was not vaccination available, then Haemophilus influenza would be a bigger deal than it shows up to be on this table. And then as kids get older, mycoplasma becomes an issue. So if we think there is pneumonia, we're going to be concerned about newborn germs in newborns, E. coli and group B strep, and in other countries more gram-negatives than just the E. coli. And then in the older children, we'll be concerned about pneumococcus, H-flu for non-vaccinated people, and then increasingly as age goes up, wondering about the walking pneumonia or mycoplasma being the issue. If we've diagnosed the pneumonia, then we're going to consider giving antibiotics, and the antibiotics will be given depending on what the age of the child is and what we think the most likely germ is. We don't have a good way to get samples of the infected fluid out of the lungs of children, and we don't have good ways to say for sure what the germ is, so we end up thinking about the likely causes based on age, and then we choose the antibiotic that makes sense. Newborns would get parenteral treatment since they often have bacteremia with their pneumonia, with either ampicillin and gentamicin, or ampicillin and cefotaxime, or perhaps just with the cefotaxime if we think that they don't have listeria. Older children that are not too sick, not retracting, not needing oxygen, if they're able to be managed as outpatients, the older babies and older children could get amoxicillin. If we're thinking that they're getting older and the mycoplasma might be an issue, we would consider azithromycin. And if they're sick enough to be hospitalized, then they're probably sick enough to deserve parenteral antibiotics, which usually means ceftriaxone or penicillin G. Some parts of the world we would still use chloramphenicol, which can work. It has about a 1 out of 5 to 1 out of 20,000 risk of bad side effects, so we don't use it much in this country. But usually amoxicillin if we're going to treat orally, ceftriaxone or penicillin G if we're going to treat parenterally. The duration of treatment is a bit debatable. We don't know really how long we should treat. In the United States, we usually say 10 days because that works and because it's a habit. In other countries where it's more expensive to treat for longer days, there are good data suggesting that for an outpatient and even for a fairly sick inpatient, usually 5 days of treatment should be adequate to cure the pneumonia. The exception to that would be if the child is very sick with complicated pneumonia, meaning pleural effusion or empyema, then we might need longer treatment. Without seeing faces and without being into all these emoticons, everybody following and questions or thoughts coming up so far?
Bill, I actually do have a question.
Okay.
This is Lance. I was curious. I'm real concerned about, I've been particularly concerned about atypical pneumonias like mycoplasma, especially in reference to like refugee camps. A lot of the protocols that we use do not provide atypical coverage like for mycoplasma. The last material that I read, or literature that I read, it sounded like it was still, they were a lot less certain about atypical organisms like mycoplasma or chlamydia pneumoniae and organisms like that. And anyway, so right now it's very uncommon to see coverage like with macrolides and things like that. I didn't know if you had any comment about that.
Yeah, it's a good point, and it comes a little bit to logic and a little bit to practicality. The logic is twofold based on germs. Around 6 weeks of age, some kids without fever have a staccato cough that's due to chlamydia, and that's when we would think about using a macrolide. In older children, as we saw in that other table, the mycoplasma is becoming more common through the school age and into the teenage years. So if we're just trying to treat the germs that cause pneumonia, then we would consider the macrolide. There's some resistance of pneumococcus to macrolides, so it might mean we would go with amoxicillin plus azithromycin and have to double cover, which adds cost. But that's what we would do if we were just thinking about what are the germs that cause pneumonia. In the context of a sick child that's febrile and tachypnic, that's much less likely going to be mycoplasma. Mycoplasma causes pneumonia, but it's more of a pneumonitis that's scattered around instead of a lobar consolidation, and kids aren't usually as sick or as tachypnic. So part of the trouble with all these definitions even of does the child have pneumonia, technically if they have mycoplasma it is pneumonia, but it doesn't necessarily look like a lobar consolidation. Mycoplasma doesn't usually kill kids, so if we ignore mycoplasma we would be scientifically incorrect, but practically we would leave kids coughing for longer but they wouldn't be dying of it. So on the practical side, I think the protocols are reasonable to say we want to save lives, so we're going with the amoxicillin. And if people do have a nagging cough for 6 or 8 weeks and it's due to mycoplasma and we didn't treat it, maybe that's not so bad. It's a hassle, but it's not a life-threatening hassle. Does that make sense, Lance?
Yes, sir. Yeah, I wonder if, and we could go back and forth. I wonder if in a refugee setting we should, as backup, for recalcitrant cases, especially in those kids that are significantly immunocompromised or malnourished, if we should have a backup macrolide if they're not getting better with the classic, oral or IV regimen.
Right, and I would certainly agree with that because between the theoretical and the practical, there are a bunch of kids and we don't want them being sick at all. The other concern would be is maybe they're not getting better because it's not just regular pneumonia, but it's become complicated pneumonia. So the child that continues to be highly febrile, maybe it's because they actually have a big pus pocket in their pleural space, and our antibiotics given orally just aren't reaching it to kill off all of those germs. So certainly the goal is to treat kids to recovery, and I would agree with you. We don't want to say, okay, we did what the protocol started as, we're done, because if a child's not getting better, then we should consider different treatment for resistant germs, whether it's a macrolide to cover the atypicals or whether it's something that treats those beta-lactamase producing germs so they can do better, or whether it's thinking about a chest film to make sure that there's not a pleural effusion. Other comments on all of this so far?
Hi, Dr. Fisher. This is Ann. Can you comment on the wheezing child who's tachypnic and febrile? And I assume that you're going to just give antibiotics in these various settings, but viruses being common, that in my mind might be another scenario where you can give antibiotics, but it may not alter the course of the clinical symptoms.
Short answer, yes, I agree with you. Long answer, wait about 4 slides and then you'll see a whole series of comments on that. How's that?
Great, thank you.
Other thoughts? All right, so complicated pneumonia, meaning an effusion, we'll need to do more. We'll need longer-term antibiotics. We'll tap the fluid to see if it's thick pus. If there's a significant amount, we'll put a chest tube in to drain it. And then there's some debate, but we might use fibrinolytics to open it up so we can break down the loculation so we can drain the pus better. And if we have a high-tech setting with a good pediatric surgeon, then we might use a little video-assisted scope to clean out the chest as well. So some kids do get complicated pneumonia. It's not that uncommon anywhere in the world, and it seems to be more common to have more pus collections in developing countries than around here. Real briefly, just to mention zinc, we know that zinc is very good for kids with diarrhea. What about adding zinc in developing countries for kids with pneumonia who might be deficient? Zinc would be easy. It's not very expensive, but it doesn't do any good for pneumonia. There have been several randomized controlled studies involving lots of preschoolers in developing countries. Zinc is good for other stuff, but it does not change the severity or duration of illness for kids with fever and tachypnea. So one more comment before we get back to your other question you just raised. Is why are kids dying of pneumonia? A study 5 years ago reported from Uganda was rather bothersome because the kids that are dying of pneumonia have usually been sick for quite a while. They'd been sick for about a week before they died. It took them a while to get any care at home. It took them a while to get to health care for help. And then even after they got to health care providers and could get help, it was still several days until they died, and most of them were dying in the hospital. The self-critiquing work done in Uganda was beautiful in that they could look to see what were they not doing appropriately, and they realized that they were often overcalling malaria and not realizing that kids could have pneumonia as well that looked similar with fever and tachypnea. And there were delays in seeking care, and not everybody was getting the best possible care. So I think this points out to us that even though kids can get sick and die of pneumonia in a hurry, usually we have time. So all of our clinical care and all of our training can have an impact because we do usually have time to impact the life of these kids. So I would summarize where we are before we get into the viral sort of question. I would summarize it saying in a clinical way, X-rays are nice, ultrasound might be the coming way to do things. Stethoscopes are great to ease our mind one way or another, but practically speaking, we're still going to use tachypnea as a diagnostic tool for defining whether a child has pneumonia. And if there is tachypnea, we'll give oral antibiotics. If they're not too sick, if the child's retracting and sicker, then they get parenteral antibiotics. But then we have the good question, what about if they're wheezy? So this is a scenario of a previously healthy 2.5-month-old has a couple days of a runny nose, congestion, 1 day of cough and noisy breathing with some fever for this scenario. On exam, the child's interactive but breathing fast, qualifies as having dyspnea, and is retracting. And with our helpful stethoscope, then we find out that the child has coarse, wheezy breath sounds. Let me go backward for a second. Kelly and Lance, thank you. I see you just put some notes in I had missed. How often do effusions resolve on their own without tapping? If it's just an effusion, like is seen with mycoplasma, I agree with what Lance said. That'll probably get better on its own. There's not usually much of it. If it's a thick, purulent effusion, it's really what we would call empyema, and those don't usually get better without draining because we get a thick pus pocket. The child might get better, but then be left with a chronically atelectatic lung and a pus pocket in the chest that's going to lead to some trouble. So Lance, Kelly, thank you. I missed your little conversation going, but I agree with it.
That's all right.
So back to our viral-sounding child. The scenario we have here of the 10-week-old sounds like a child that has what diagnosis? Do we want to call this one viral?
Bronchiolitis.
I see asthma. Okay, so bronchiolitis could do it. Asthma could do it. Asthma typically would be diagnosed if this is a recurrent problem. So this could be a child with a cold and a first bout of asthma, or it could be bronchiolitis with RSV. And in fact, if we look at kids with RSV bronchiolitis, this will be a typical presentation, even though other things could do that. Some of us have the idea that bronchiolitis is more of a problem in places that have winter, but studies have been done in other parts of the world. A study done in Kilifi, Kenya, looked at tens of thousands of kids admitted to a hospital. Thousands of them had pneumonia, and 15 to 20% of those that fit other diagnostic criteria as having severe pneumonia actually had RSV. 1 out of 300 kids in the community in their preschool years were hospitalized because of RSV. So RSV is a problem not just in cold, wintry climates, but even in delightful places near the Indian Ocean coast of Kenya. What about parts of Asia? A little bit smaller study, but with a few hundred kids in the first year of life in Thailand. They looked at people that had lower respiratory tract infections, so not just a cold, but fever and tachypnea. Nearly a third of them had RSV, and it followed the seasons where it was during the wetter season. A fair number of them had influenza. So even though our main concern for life-threatening disease is going to be the possibility of bacterial pneumonia that needs antibiotics, we realize that a fair number of these kids, even in developing countries, are going to have a viral sort of infection. Besides RSV, there are other causes of bronchiolitis. Human metapneumovirus and bocavirus are relatively newer described, more recently described germs. The normal cold viruses can do it as well. And certainly influenza and para-influenza can be big problems. So what treatment might help? If we think this 10-week-old has bronchiolitis, what treatments might be useful for the child? Lots of treatments have been proposed, but you've also been able to look and evaluate evidence of how good they are. Supportive care seems to help. People need fluids. We don't want them to get dehydrated. Some would go to NG feedings or IV fluids if the child's not able to feed well. Some would say if the child's breathing too fast, don't fill up the stomach to push on the diaphragm. But nasogastric fluids should be adequate for most kids with bronchiolitis. If they're going to be sick for more than a couple of days, we'll have to find some way to give them the nutrition. Nasogastric feedings can help that, but most kids should be able to eat and drink some on their own. Suction provides temporary relief. clears some of those thick nasal secretions. Deep suctioning makes medical care providers feel very useful when they see thick, slimy secretions removed, but it's not clear that deep suction actually changes the clinical course in a favorable way. We get stuff out, but we also irritate and stimulate the child in ways that might not help. Oxygen is useful for hypoxic kids. There's a fair bit of debate about what counts as hypoxia. We probably don't need to keep the oxygen saturations normal, but if we keep them above 88 or 89, that's probably good enough to prevent the hypoxia from causing more deterioration. People have looked at chest physical therapy, pounding on the chest. It's totally logical. Loosen the secretions, help these weak little babies cough them out. Makes good sense, and it's shown that it causes the child more distress than it does good, so kids actually get worse if we pound on their chest to try to get them to clear their secretions. So supportive care is good, but it comes down to fluids and nutrition and oxygen and some gentle suction. There are evidence-based guidelines. Pediatricians in Cincinnati have published very helpful guidelines about bronchiolitis that are useful for adaptation in lots of parts of the world, and those are available online. What about decongestants? Lots of people like cough suppressants and decongestants. Seems to be that even culturally in some developing countries, to not give medicine seems to be a crime. But we do know that medicine can have bad effects. Cough suppressants and decongestants are not at all effective for bronchiolitis. Some kids have bad outcomes because of toxicity. So the right answer is just to say no, to not give cough suppressants and decongestants for kids with bronchiolitis. Albuterol, sometimes called salbutamol. Bronchodilators are useful if the child has asthma. So Kelly, you raised the possibility that the child could have asthma. If the child has asthma with the cold, then bronchodilators would help. The challenge is in young children, they might not have had a previous bout, and we don't know if it's asthma. Most kids presenting like this do not have asthma, but perhaps 10% of them will. So Kelly's good idea would lead us to say, yes, we should give albuterol as a trial. If it helps the child, meaning there's greater air movement in the few minutes right after giving it, then we would say it's bronchiolitis with asthma, and we could continue the asthma treatment. But overall, if we look at lots of kids with bronchiolitis, the albuterol does not make any significant difference, and so we're not going to use it. So we often will give a therapeutic trial. I see that, Lance, you just asked a good question. Yes, if we were talking about chest physical therapy with kids with cystic fibrosis, yes, that's very useful. Kids with bronchiectasis, cystic fibrosis, and other problems, chest physical therapy is very good. For kids with bronchiolitis, it causes more trouble than good because they're young kids and they get riled up and bugged, and then they might gag and choke more. Other questions as we're going, or should we keep moving? All right, other treatments, we'll run through a few things because they don't help. People have tried epinephrine, also called adrenaline. People have tried that. It actually makes kids have to stay longer in the hospital. So using epinephrine is not useful for kids with bronchiolitis. People have looked at the effects of steroids. Steroids don't do any good for kids with bronchiolitis. If the child has asthma with their bronchiolitis, then yes, we would give them albuterol and steroids, but if it's just straight bronchiolitis, and if the initial albuterol trial did not make a marked difference, favorable difference, then we would not give albuterol, we would not give the steroids. There are conflicting data about the usefulness of hypertonic saline. A good study done several years ago and looking at several studies, a Cochrane review, suggested that hypertonic saline could shorten lengths of stay by helping clear secretions better. This is more like chest physical therapy from the inside, by having hypertonic 3% saline to help suck out some of the fluid and decrease the swelling. So it looked like that could help. Other studies have looked at hypertonic saline, and it doesn't seem to help much. This study quoted here was actually in kids that were getting epinephrine anyway, so I'm not sure that that didn't confound the answers. But for a lot of kids, it looks like hypertonic saline in the 3% solution delivered by nebulizer can actually help them get a bit better. So evidence-based medicine would say there's no consistent evidence to support the use of antivirals, we didn't talk about, but of antivirals, bronchodilators, or steroids, and yet about 2/3 of kids with bronchiolitis as recently as 6 years ago were still getting those kinds of treatment in the United States. And we know it's much more difficult to withhold treatment than it is to give it, but giving it teaches communities that we need to have expensive care. Giving it might lead to some adverse side effects. So sometimes we need to do what's right, and people will learn that it's the appropriate thing. So if it is bronchiolitis, what's useful? Fluids, nutrition, and oxygen. What do we not give? Most of the other stuff. And we shouldn't forget prevention, that we can help people decrease smoke exposure, whether it's from cigarettes or cooking fires, and hand hygiene can prevent the spread. Kelly, you asked a good question about the oxygen there. I would say for any age, in a place that's near sea level, using a number of 88 or 89 is a reasonable cutoff to keep the oxygen saturation. Using a higher cutoff tends to keep kids in the hospital for longer, but doesn't change ultimate outcomes of how they do. So for kids with bronchiolitis of most any age, a number of 88, 89, or 90 something in there is reasonable. There have not been great studies of that, so I'll couch what I said as just being an opinion. There have been some studies showing that 92% as your target saturation is just as good as 94%. There have been fewer studies looking at the 88, 89 number, but that should work. So if kids are in the PICU, that's a good point. Then they're sicker, they've got a lot else going on, and so we can be generous as long as they're there. So I would not necessarily say we have to keep them hypoxic when we know they're in the hospital, but I would not use that higher number as a reason to keep them extra days on oxygen. So for keeping them cared, we could keep their oxygen saturations in the 90+ range, but when it's getting time to go home, if they're above 88, I would think that's good enough to go home. And I agree completely, Anne. The respiratory rate and how hard they're working are more useful than the pulse ox. Some of us are old enough to think that the pulse ox is a test and not a vital sign, and so we shouldn't believe it too much. So yeah, good comments by Kelly and Anne. Thank you. So what is IMCI? Another voting time, quick, we're getting towards the end here. How many have no clue what IMCI is? How many say it's something for other people to do? And how many of you are living IMCI, A, B, or C? We'll see if people want to type in or call out votes.
Very basis of the VSP.
The basis of ESP?
VSP, the Village Samaritan program. I was going to talk to you a little bit about that. This is Tom Wood, Dr. Christian.
Okay.
Yeah. So we've had some people that have indicated in there's a little actually chat feature that some people are utilizing, the little A with the square around it, just next to your emoticons. You can use that to vote.
Ooh, now I'm seeing that come through. Oh, nice, nice. Okay, so good. For those of us that didn't have a clue, IMCI is the Integrated Management of Childhood Illness. It's a holistic approach to child health and development, implemented through international agencies via local governments. So what it does is it gives an algorithmic plan to the care of sick children by integrating everything they might need. It focuses on acute respiratory infection, our topic today, as well as diarrhea, measles, malaria, and malnutrition. The system links home care to primary frontline care and to referral care, and it's being used in about 100 different countries now. It's been proven to be cost effective, and it can actually avoid misdiagnoses and save a lot of lives. So for people working in other countries where the approach is used, then we would need to get familiar not only with IMCI in general, but it's adapted for each country. One of the beauties of it is that it will help us not forget about pneumonia and malaria as both being causes of fever with tachypnea. So some studies have been done for this. If we pay attention to respiratory rate, it helps us detect pneumonia. It makes us identify severe malaria with a need for the hospital. But it will also be our reminder to us that it's a screening thing to do, and so we need to keep thinking. If we just go by IMCI, we're going to overdiagnose pneumonia and underdiagnose bronchiolitis. That might not be bad because we'll waste a few antibiotics, but we'll avoid all those deaths, or at least a lot of those 1.2 million annual deaths from people that do have pneumonia and weren't getting treatment. So to wrap things up, fever and tachypnea in a child, what should we talk about? We should not forget malaria. Malaria causes fever, and the sickest kids with malaria have tachypnea, and tachypnea is a sign of a poor prognosis. We should realize that it might just be a viral infection, but viral infections are going to respond to supportive care and not be hurt by antibiotics. Bacterial infections can be saved. The children's lives can be saved by giving antibiotics. So if we're thinking about pneumonia, then we'll give a good antibiotic for the possibility of pneumonia. And along the way, we should wash our hands because clean hands do save lives and they cut down on the spread of viral and bacterial pathogens. So we said that 1.2 million kids are dying before school age each year. We can do something about it. We'll not forget to immunize and clean up the air around kids and clean their hands. But we've talked mostly about using respiratory rate as a good clue to diagnosis, coupling it when possible with x-rays and maybe eventually ultrasound, and certainly being real doctors and using stethoscopes. Treatment is based on antibiotics and, in the case of bronchiolitis, good supportive care without overusing unneeded medicines that might have side effects. So back to our initial 10-month-old child, what's needed to make a diagnosis? Respiratory rate, maybe something else. What treatment's likely to help? An antibiotic if the child's tachypnic, antimalarial if there's a malaria smear that's positive, and supportive care for all, but especially if it's likely just bronchiolitis. And I am open to more questions and discussion and comments or rebuttals or anything else.
Hey, Dr. Fisher, this is Tom again. When I mentioned the village... We're getting big feedback.
Tom, I started to hear you say something and then I lost you.
Okay. I was going to tell you the Village Samaritan program, a lot of, the 1.2 million children that you mentioned die, as you're very well aware, because they don't get the care, and there are many reasons for them not getting the care. Primary among those in developing countries is the remoteness of where the parent lives to where care is available. So what we have done is we combined an integrated community case management, IMCI, and put a heavy spiritual overlay on that. And we're calling that program Village Samaritan. And what we're actually doing is taking healthcare training, very basic healthcare training, with the diagnostic algorithm out and training villagers, very carefully selected villagers in these remote villages to provide the first interface to medicine. Many families, as we've talked to them in developing countries, where you get out to where it's 3 hours plus, and that's what we've looked at as a threshold for the program, 3 hours plus to the nearest available care, they don't take the children. And the reason why is because they tell you that, one is it's an all-day process to get the child into care and then back home. Two is if they do get them into care frequently, the antibiotics are not available. If they're not available, they get a prescription for those antibiotics, which they cannot afford. What they have developed, it sounds callous, but keeping in mind their situation is what they've developed is the child is replaceable philosophy. We don't want that to continue to be. We want to save those children's lives with the idea that if we do that, then we're helping the entire village, and that's what we have seen happen. But, diagnosing that child with tachypnea, is something we're training them to do, and then providing a first-line antibiotic to them when they've done that. And the thing about the Village Samaritan is where it's not several days when the child gets to care, because we assign them a set number of households within their village that they are responsible for, and those houses that they're responsible for are all within a few minutes walk of their house. So, you know, we've got this program in place in 6 villages in Honduras. We're seeing very good results from it, and we're hoping to learn lessons from those 6 villages and then to promote it into other places. So it's, you know, the remoteness to care. What we say is when they can't get the care, we take care to them. So that's what our program's about.
That sounds totally fantastic to me. Are you doing it just for pneumonia? Do you have malaria treatment, or is there malaria in those parts of Honduras?
We've expanded what most countries are doing with ICCM, Integrated Communication Management, in that they are looking at malaria or pneumonia or, diarrhea, and having the village healthcare worker provide only care for one of those. Our program trains people 24/5, 24/6, 6 days a week and keep them, available for training for a period of about 6 weeks. Right now, it varies depending on whether we're dealing with, the education level of the people. We train them intensely for about 6 weeks, and we train them in basic first aid, and then the 5 illnesses, the 5 that you mentioned, the big 5. The one we can't address a lot of is malnutrition, other than, the importance of good nutrition they're teaching. But it's malaria, pneumonia, and diarrhea are the big 3 that we're going after.
That sounds like a totally fantastic program, to get the care to kids when they need it with appropriate care, and then when you've got this whole spiritual thing tied in to be able to reach people. That sounds totally fantastic.
Yeah, we add to that, then where mobile phone technology is becoming available worldwide and spreading very rapidly, we have those village Samaritans in touch with a nurse manager, and our nurse manager in Honduras has told us that she can manage up to 25 village Samaritans. We're waiting to see if that's the case. We think we will keep her caseload smaller, but she will be in daily contact and, with those village Samaritans, advising them, counseling with them, and then also, we have several danger signs built into the training program, and when one of those danger signs is encountered, we go to immediate referral. And we've worked out a network within Honduras, and we hope to work it out in other countries, where the child gets referred and then gets priority care because they're coming in from somebody where the diagnosis has already been preliminary made.
That is fantastic. That's the sort of application of sound science and good technology right to the village and home of the patient. That's exciting. Well done by you guys.
We're watching to see how it develops and looking to find all the support we can. So
that's very good.
Mary Lou, did you have a question for Dr. Fisher?
Dr. Fisher, thank you for a very informative presentation. My question is, with a 10-week-old and bronchiolitis, how old do children get that still have bronchiolitis versus them having, if they're wheezing, versus having an asthma flare versus having pneumonia? That's my first question. What's kind of the cutoff date for cutoff year for bronchiolitis, number 1? And then number 2, I read a statistic once that up to 25% of children that are diagnosed with pneumonia, deaths, may in fact have TB. Can you address that also?
Excellent questions. There are a few data to talk about the age of bronchiolitis. It seems that 90% of kids have had an RSV infection by age 2. And if we give good serology testing, it's probably closer to 100% of kids are infected with RSV before the age of 2 in pretty much any part of the world. But that doesn't mean they're totally immune, because people can have multiple infections with RSV throughout their life. So in terms of tachypnea, if it's an otherwise healthy child, it's unusual to be very sick and tachypnic and need a hospital with bronchiolitis after the first birthday, even more unusual after the second birthday. So that's not the age of just getting infected, but the age of getting sick enough. Older kids with RSV are more likely just to get a cold with congestion, but not to get severe pneumonia or the lower respiratory tract troubles. So 1 to 2 years would kind of be a cutoff when you're going to think if they're very sick, it's maybe more than just the bronchiolitis. The question of asthma, if they've had recurrent bouts, you'll certainly be thinking it could be asthma with their cold or bronchiolitis at the same time. And that's where I find the albuterol trial to be very useful. If the child seems a bit better after a dose of albuterol, then that suggests that the child probably does have asthma in addition to the viral infection. So something about 1 to 2 years of age to be very sick with bronchiolitis, and it's especially in the first 6 months of life that children are very sick with bronchiolitis. The enlarged exception to that would be kids that have underlying lung disease from prematurity or congenital heart disease can get extremely sick with bronchiolitis even a little bit later. The question about TB is tough. TB is very common in other places. Kids can have TB and then get a superficial or a secondary infection on top of it. So I've not heard the statistic about 25% of pneumonia actually being due to tuberculosis. That sounds high to me, but in areas where there's lots of tuberculosis, it could well be that lots of those kids do have underlying TB and then get a bacterial pneumonia on top of it. So the good reminder in your question is that we should never forget about TB. TB wouldn't explain always the acute deterioration, but we do need follow-up. We do need to know who's got some chronic cough and chronic trouble growing, and so we need to be thinking about TB. When we add the HIV bit into the question, sure, HIV can give more TB and more other kinds of lung infections. So yeah, I appreciate the question because we definitely need to keep those more chronic things in mind even if we see the acute flares of pneumonia on top of it all. So yeah, very good questions. Thanks, Mary Lou.
Thank you. Kelly, now, did you have a question?
Can you guys hear me?
Or was it Kelly Sides? Hey, Kelly.
Can you guys hear me?
I hear you now.
Okay, my question is, so I was coming from a really low resource setting working in South Sudan, and recently in the last year I've been working in a PICU and a pediatric ICU, and we're treating a lot of the same upper respiratory infections, but we treat them really differently. And so I guess I just wanted to ask about the treatment sequelae for pediatric pneumonias and bronchiolitis. There was one of your slides about RSV in Kenya that said about 2% of the patients admitted die. And the setting I was in before, we maybe had an oxygen concentrator, but you know, we were doing all the things that you were mentioning previously with antibiotics, but we very rarely transferred our pneumonia, upper respiratory tract infections. Either they didn't make it or not. And here in the States, you know, we put kids on BiPAP, we intubate them, and I guess from what I've seen, I see that we've intubated kids that we wouldn't have been too concerned about over in Sudan. We would have let them kind of ride it out with a couple liters of oxygen. And which also can lead to other complications. And I guess I'm just wondering, my first part of my question would be, what percentage of kids do you think actually need that further respiratory support or airway support? And then in a low resource setting, what is our window for transferring a kid to a regional center? Is it after the first round of antibiotics? Is it after 72 hours? Is it after the first round of antibiotics isn't successful? Is it going back to respiratory rate and rhythm after a certain period of time? Just like looking, what is our window there for kids who would need the further support?
Yeah, great question. I wonder if in 10 years we're going to look back and realize lots of what we're doing now is kind of silly and over-treating, but we don't know that yet. For bacterial pneumonia, I think the question really is if oxygen's not enough, then the ventilatory support would just be that little window while they're about to turn the corner with more oxygen. So I think it's unusual that for bacterial pneumonia, the ICU setting is going to be needed all that much. And if it is, it should be short-term, and if you can get antibiotics going quickly, then they shouldn't get that sick from it. The challenge is bronchiolitis. Some of those kids do need a little pressure support, maybe not so much breaths, but sometimes even some breaths with the pressure support. So those kids would need help. If you had blood gases, those that are retaining oxygen or you're not able to keep their those that are retaining carbon dioxide, or if you're not able to keep their oxygen saturations up with all the oxygen you can give, then if you had an ICU setting handy, you would think about it. The window of opportunity is probably fairly limited in a South Sudan setting. It's possible with a tight mask on a face to give a little bit of PEEP, positive end expiratory pressure, even with a bottle with water in it and a tube going into it. So the bubble bottle kind of PEEP, sometimes that can help keep the heavy bronchiolytic lungs open a little bit. But to actually have ICU care and BiPAP sort of ventilatory pressure support, that's going to be rare. So the timing, if you're in South Sudan, you probably don't have higher resources available to you, and you'll do what you can do and see where they get. But a fair number of kids with bronchiolitis do need a day or two of some support. What percentage? I don't know. I'm biased now by an American setting. It seemed a lot less common when I was working overseas longer term. So how many really need it? Hard to say, but you get what you can. I don't think we should have pressure and ventilatory support, but if they're retaining too much carbon dioxide and we can't keep their oxygens up into the high 80s at least, and we have it available, then we would think about doing that. The question of sequelae, because of all this treatment, sure, ventilatory support can top lungs and lead to some scarring, but when they're that sick, it's hard to know if it was really the ventilation or their disease. So I guess if we have treatment available, it wouldn't be bad. So I think I'm hemming and hawing and not really answering your question, but I'm sympathizing with it.
In regard to time, I'm going to draw things to a close here. Phil, I just had one quick comment before I do that, or two quick comments. Number one was your comment in regard to zinc. Is that still on the IMCI guidelines, or I thought that was still on the IMCI guidelines for treatment of acute respiratory illness?
That is a good question, and I don't know. IMC guidelines are changed for each country, so developing countries, there's not zinc deficiency, you don't need it. I actually don't know if anybody still has it on for respiratory infection. It should be there in the IMCI guidelines in developing countries, but I don't know. Does anybody else know if IMCI guidelines in your countries still have zinc on for pneumonia?
You don't know the answer? Okay. No, I'm not sure. I thought I had just recently read that it was still on there. But the only thing, a comment I was just going to put in a plug for ultrasound. Ultrasound is just an incredible tool in developing countries. It's an incredible tool anywhere. But I really encourage, especially the family practitioners and internists like myself, we can use ultrasound too, so it's a great tool and encourage you to use it. As Dr. Fisher has pointed out, it's even very likely beneficial in the diagnosis of pneumonias and certainly effusions like empyemas. So if you could, we really need to draw it to a close here, so Kelly, I can try and find out answers for you after. I'm going to go ahead and close this in prayer. Dr. Fisher, let me say on behalf of everyone here, a fantastic presentation. We are indebted to you for this presentation. It was excellent, and thank you so much for taking time out of your busy schedule.
And thanks to all of you. And Kelly, if you email me, I can get you the bubble bottle CPAP idea too.
Great. I'm going to close this in prayer, and then we'll adjourn. Dear Heavenly Father, thank you so much again for today and the opportunity that we have to use this technology, Lord, to further our understanding so that we may treat people in developing countries that are underserved and we may present the gospel. And it's in your name we pray. Amen. Amen.